Achondroplasia is a genetic disorder, musculoskeletal disease condition. Look at this picture, shows that shortening of limb and radiographic findings. Look at this shortened long bones, narrowed spinal canal, etc. Detail going on. Introduction. Achondroplasia is a rare genetic disorder that results in dwarfism. It is the most common form of short-limbed dwarfism and primarily affects bone growth. This condition stems from a mutation that affects the conversion of cartilage into bone, especially in the long bones of the arms and legs. People with achondroplasia typically have normal intelligence and lifespan but may experience various orthopedic and medical complications. Definition. Achondroplasia is a genetic disorder characterized by abnormal bone growth that result in short structure with disproportionately short limbs, a large head, and distinctive facial features. It is caused by mutations in the FGFR3 fibroblast growth factor receptor 3 gene. Etymology. The term achondroplasia comes from the Greek word a meaning without, chondros meaning cartilage, and plasia meaning formation. It refers to the impaired conversion of cartilage into bone, particularly affecting the growth of long bones. Epidemiology. Achondroplasia occurs in approximately 1 in every 15,000 to 40,000 live birth worldwide, making it the most common form of dwarfism. About 80% of cases result from new sporadic mutations, while the remaining 20% are inherited in an autosomal dominant pattern. Types. Achondroplasia is a single specific disorder, but it may be categorized based on the inheritance pattern. 1. Sporadic Achondroplasia, most common, caused by new mutations in the FGFR3 gene. 2. Inherited achondroplasia, passed from parents to child in an autosomal dominant pattern. It should be distinguished from other forms of Dwarfism such as hypochondroplasia, thanatophoric dysplasia, spondyloepiphyseal dysplasia. Causes: gene mutation. Achondroplasia is caused by a mutation in the FGFR3 gene, which regulates bone growth. 2. Autosomal dominant inheritance. If one parent has achondroplasia, there is a 50% chance the child will inherit it. 3. Spontaneous mutation. About 80% of cases result from new mutations in children of average height parents. Risk factors: 1. Parental age. Advanced parental age, usually over 35 years, increase the risk of new mutations. 2. Family history. A parent with achondroplasia increases the risk of transmission to offspring. Complications: 1. Orthopedic, bowed leg, spinal stenosis, hyphosis, lordosis. 2. Neurological, hydrocephalus, spinal cord compression. 3. ENT issues, recurrent ear infections due to narrow astrocyne tube. 4. Respiratory, sleep apnea due to narrowed upper airways. 5. Obesity, common due to decreased physical activity. 6. Psychosocial, social stigma, low self esteem. Pathophysiology. Pathophysiology of achondroplasia, step by step process. 1. Gene mutation occurs. A mutation develops in the FGFR3 fibroblast growth factor receptor 3 gene, usually as spontaneous mutation, are inherited in an autosomal dominant pattern. 2. FGFR3 becomes overactive. The FGFR3 gene becomes overactive, leading to excessive inhibition of cartilage cell proliferation, and differentiation. 3. Disruption of endochondrial ossification. The overactive FGFR3 disrupts the endochondrial ossification, which is the process by which cartilage is gradually converted into bone, especially in long bones. 4. Impaired growth of long bones due to abnormal cartilage formation and reduced chondrocyte activity. Long bones fail to grow normally, resulting in disproportionate short structure. 5. Skeletal abnormalities develop: short limbs, large head, phalangeal bruising, spinal curvature, and other characteristic. Skeletal changes occur due to improper bone development and ossification. 6. Associated complications arise. Secondary effects such as spinal stenosis, hydrocephalus, joint issues, and respiratory problems can develop due to abnormal skeletal structure. Signs and symptoms: 1. Short structure, adult height 4 feet. 2. Disproportionately short arm and leg. 3. Large head with prominent forehead. 4. Flattened nasal bridge. 5. Short fingers. 6. Limited range of motion at elbows. 7. Bow legs. 8. Spinal curvature. 9. Recurrent middle ear infections. 10. Delayed motor milestone in infancy. Medical diagnosis: 1. Clinical evaluation based on characteristic physical features and growth patterns. 2. Radiographic imaging: short and long bones, narrowed spinal canal, and characteristic pelvic shape. 3. Genetic testing: detection of FGFR3 mutation. Definitive diagnosis. 4. Prenatal testing: ultrasound detects shortened limbs around second trimester. Amniocentesis or cryonic villus. Sampling CVS for FGFR3 mutation. Nursing diagnosis: 1. Impaired physical mobility related to skeletal deformities. 2. Risk for injury related to abnormal bone growth. 3. Ineffective breathing pattern related to restrictive thoracic abnormalities. 4. Disturbed body image related to physical appearance. 5. Risk for developmental delay related to motor difficulties. Medical management. 1. Surgical interventions, lymph lengthening, decompression for spinal stenosis. 2. Treat complications, ENT tubes for infections, treatment for hydrocephalus, bracing for spinal deformities. 3. Growth hormone therapy, limited effectiveness. 4. Versoritide, a new FDA approved medication that targets the growth pathway in children with open growth plates. Nursing management. 1. Monitor for signs of hydrocephalus, respiratory issues, and developmental delays. 2. Encourage physical therapy to promote motor development. 3. Support parents with education and genetic counseling. 4. Promote safe environment to prevent falls and injuries. 5. Assist with adaptive devices to enhance mobility and independence. Treatment options. 1. Pharmacological, vasoritide in children, pain relief for orthopedic symptoms. 2. Surgery. A. Lymph lengthening. B. Spinal decompression. C. Correction of bowed legs. 3. Physical and occupational therapy. 4. Audiologic monitoring and ENT treatment. 5. Orthotic devices for spinal curvature and leg alignment. 6. Genetic counseling for families. Psychosocial medicine. 1. Counseling and therapy to address self-esteem, body image and emotional challenges. 2. Support groups connect families and individuals with dwarfism for shared experiences. 3. Educational support, special accommodations at schools, height accessible facilities. 4. Social skill training, promote confidence and coping skills in social interactions. 5. Advanced programs, promote inclusivity, disability rights, and public awareness. Prevention. 1. Currently no way to prevent achondroplasia, as most causes arise from spontaneous mutations. 2. Genetic counseling is essential for at-risk couples, prenatal diagnosis can assist in preparing families for care needs. In conclusion, achondroplasia is a genetic condition that profoundly affects skeletal development, leading to short structure and various health complications. Despite physical limitations, individuals with achondroplasia often lead fulfilling lives with appropriate medical, surgical, and psychosocial support. Early diagnosis, intervention, and an inclusive environment are crucial for optimizing health outcomes and quality of life. Multidisciplinary care and ongoing research, example targeted therapies like vasoritide, offer promising improvements in managing this lifelong condition. Thank you. Have a nice day.